So again, my point that tuberculosis is becoming a complicated disease. A greater proportion of TB cases are clinically complicated and require specialty services, as the patient that I described for you. That there are more TB risk assessments and preventive interventions that fall into the province of primary care. But there needs to be more integration both with primary care and specialty services to address TB in today's context because of the complexity of the disease in which the context in which we see it, and also the number of risks that are encountered in primary care settings that never make it to the TB clinic. And that this sort of integration really requires much greater reliance on private and academic providers and facilities to deal with some of these complicated situations. So in the past, we've thought about TB control programs being the real essential part of providing TB care. That's no longer true. TB control programs provide the necessary stewardship for tuberculosis control, but they have to interact, as I've said, with primary care, including the private sector, specialty care, again, including the private sector, and with research entities, research facilities that can provide operational and implementation research, as well as developing new tools and approaches to integration of innovations. It's a much more complicated set of services that are now required to deal with tuberculosis in the way that today's context demands. So just to take the example of HIV, TB programs have to interact with primary care in terms of the HIV provider screening for tuberculosis, providing treatment of latent tuberculosis infection, and managing the antiretrovirals, which are a major factor in reducing the risk of tuberculosis among those with HIV. Specialty care facilities are often called on to deal with the broad differential diagnosis of symptoms in people with HIV infection and the need for more complicated and invasive tests to make these diagnoses. Likewise, specialty care services are often called on to deal with immune reconstitution syndromes, drug toxicity and drug interactions, and evaluation and management of other opportunistic infections, as well as management of antiretroviral therapy. Diabetes is a very important risk factor for tuberculosis that's increasingly recognized. I'll call your attention to the third bullet there that says 3 cohort studies gave a relative risk of 3.11 for diabetics. That means diabetics are 3 times more likely than non-diabetics to have tuberculosis. And that in the case control studies, the odds ratios ranged from slightly over 1 to as high as almost 8. So it's pretty clear that diabetes is a potent risk for tuberculosis. And importantly, diabetes incidence, or prevalence rather, is estimated to increase quite markedly by 2025. The blue bar estimates the prevalence in millions of cases in 2025. So that this is going to be a risk factor that is increasingly prevalent and that is likely to be associated with increased numbers of tuberculosis cases. So tuberculosis screening should be undertaken in diabetics as a matter of routine. And just again, looking at the interaction of TB control, primary care, and specialty care, that primary care providers often provide care for diabetics And as part of that care, they should be screening for TB. They should be considering treatment of latent tuberculosis infection in those who have a positive tuberculin skin test or interferon gamma assay. And they generally provide the diabetic management. And good management of diabetes is an important way to minimize the frequency of diabetes, frequency of TB among diabetics. Specialty care providers, again, broader differential diagnosis, need for more complicated tests, and treatment for drug toxicity, drug-drug interactions, and management of particularly of complications of diabetes, including coronary artery disease, renal failure, and other opportunistic infections. Smoking is increasingly recognized as a risk factor for tuberculosis, and there are a lot of people exposed directly to cigarette smoke. Smoking, as this man does, taking his mask off to do it. This is a systematic review that was done, the relative risk of smoking for development of tuberculosis, and the red bracket is around current smoke, those studies that looked at current smokers. And you can see that, again, the relative risk overall is about 2.2 for smokers, but is higher for those who are current smokers. This gives us an intervention that can be applied, that is smoking cessation. And again, this is something that is generally done more in primary care services. Let me conclude with both good news and bad news. I'm not going to discuss MDR tuberculosis, but I will show an example, a successful example. This is William, who I saw in Tanzania in January of 2012. He was 19 years old, was admitted to the hospital weighing 33 kilos. You see him there in the left-hand photo looking very emaciated, and in the right is his chest film showing extensive bilateral tuberculosis. Again, on admission, this was 6 months later after treatment in the Tanzania program for treating multiple drug-resistant tuberculosis at Kibongoto Hospital. He is a healthy, good-looking, active, intelligent young man who, upon being discharged from the hospital, went back to his home in Dar es Salaam and volunteered as a healthcare worker in the tuberculosis control program. A very good result from a very complicated situation, a near-death experience. And MDR care is complex, complicated, expensive, but often is the last best chance for a cure. So I'll just leave you there with this success story, point out that it's far better to prevent MDR than to treat it, but that nevertheless, treatment can be successful and patients can recover fully. So thank you very much for your attention. Thank you.